Welcome to New Directions in the Management of Acute Heart Failure, presented by the Penn State College of Medicine. During today's program, we will discuss the evolving science of acute heart failure management. My name is Dr. Clyde Yancy, and I'm Chief of the Division of Cardiology at Northwestern University Feinberg School of Medicine in Chicago. I'm pleased to serve as chair for this important educational program and as co-chair for the whole suite of CardioCare Live programs. Today's session is a live, interactive program that allows us to take questions in real time throughout this presentation from you. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. That was like perfect.
That was the dress rehearsal.
You need to reset. We're going to do that again.
All right.
Nothing on here.
All right.
We'll never be able to do it that good again. It was a 1 in a million.
Everything was good. You were fine. That was good energy. Start from the beginning. Stand by. Do countdown.
I need like a minute of your time afterwards because I know that you have some interest in the next level up. My inbox is flooded with job offers, and I just need to make you aware of some
Sure.
stuff that's out there.
Sure.
You'll never leave, but you need to know what's out there. And O'Connor would blame me, I'm sure.
10 seconds. Here we go. 10, 9, 8, 7, 6.
Welcome to New Directions in the Management of Acute Heart Failure, presented by the Penn State College of Medicine. During today's program, we will discuss the evolving science of acute heart failure management. My name is Dr. Clyde Yancy, and I'm Chief of the Division of Cardiology at Northwestern University Feinberg School of Medicine in Chicago. I'm pleased to serve as chair for this important educational program and as co-chair for CardioCare Live. Today's session is a live, interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I'd now like to introduce today's presenter, Dr. Michael Felker, Professor of Medicine and Chief of the Heart Failure Section at Duke University School of Medicine. Mike, thanks for joining us today.
Thanks, Clyde.
It's
Pleasure
really
to be
good
here.
to see you, and I'm delighted that we can have this opportunity. Before we begin, we'd like to raise several questions to you, the audience, using a few anonymous polling questions to really help you set the stage for our discussion today and to help us understand where we're beginning. We want to emphasize, again, this is an interactive program, so feel free to engage with us right now. So let's start with the first question. In an average week, how many patients do you see with acute heart failure? There should be several answers to scroll by on your screen. Now, please indicate your response now so we can understand what your activity is like. I wonder what they'll tell us.
Yeah.
We should take the poll ourselves
Duh.
and then come up with our own answers to this.
None of the above.
None of the above. Okay, so Michael, the answers have come in. So 54% of the audience says 0 to 5, 25% says 6 to 10, 7% is 11 to 15, and 15% are hardcore. 13% of them are seeing greater than 15 patients.
Yeah.
So what do you think about that splay?
I mean, that's, I think, representative of what we see clinically and we'll talk about today. It's a growing problem, and every sort of clinician, internist, hospitalist, cardiologists are seeing these patients more and more frequently.
Yeah, I like the notion that this really explains the breadth of physicians that are involved in taking care of patients.
Yeah.
And the real question is there any difference when you take care of 15 or more a week
Yeah.
versus 0 to 5? And we should try to
Great
get into
question.
that. So let's get into the second question. The second question is this. Serum BNP levels are most useful in A, establishing a heart failure diagnosis, B, assessing the clinical course of patients with heart failure, C, distinguishing between systolic and diastolic heart failure, and D, guiding treatment decisions for patients with decompensated heart failure. 4 great choices. Please vote now so that we can share with you the answers of your responses. Let's see if we can get something a little bit faster this time. I think the answers are coming in. While those answers are being tabulated, let's go ahead and do the third question so we can stay up with our time. For which of the following is there robust evidence for use in safely alleviating fluid overload in patients with heart failure? Diuretics is A, inotropes B, ultrafiltration C, vasodilators D, all of the above, or none of the above, and I think the key consideration here is safely alleviating fluid overload. Please indicate your response now, and we'll discuss both of these questions as the answers become available. So let's talk about the BNP question because we have that answer available. And I'm going to start with D, guiding treatment decisions for patients with decompensated heart failure. What percent?
You're asking me to guess?
Yes, guess.
I'd say, I don't know, 5 or 10% maybe?
Less than 5%.
Yeah, good.
So lots to talk about there. Distinguishing between systolic and diastolic heart failure, about 10%. Assessing the clinical course of patients with heart failure, 60%. And then establishing a heart failure diagnosis, the original indication, 25%.
Interesting.
So that is very interesting. And let's see if we've got our tabulation now for safely alleviating fluid overload. And I can't wait to get your perspective on this. 40% say diuretics, 0% says inotropes, 10% says ultrafiltration, vasodilators is 0%. All of the above is 40%, interesting. None of the above is 10%, and I know some of this is going to be in your presentation. So this is a good place to start. We have a breadth of users. Some see patients infrequently with decompensated heart failure. Some seemingly do it every day. BNP is all over the map with the exception of those who specifically say they use it to guide chronic ambulatory therapy. That's very interesting. And now we have some interesting data about the safety of drugs used to alleviate decongestion. It looks like most people say any of the above are at least safe to do. So let's get going.
It's a hard question. So thanks again, Clyde, for the opportunity to be here. I think this is a great area to discuss, and we'll try to cover some tried and true therapies that we use every day and also some of the new things that are potentially in the pipeline. So first, I think it's good to make sure everybody's on the same page in terms of what we're talking about. So the phrase acute heart failure all over the literature, but just a working definition, you're talking about patients who have new or worsening symptoms of heart failure. The phrase acute seems to imply that they come on rapidly, but in some patients, as we know, they can come on more slowly. They have to have sufficient severity that the patient is not going to wait till their next clinic visit. They're coming to the emergency department or urgent care. And finally, there's this mandate for some sort of urgent treatment that can't wait until next week. Anybody who reads the newspaper knows that this is a huge problem in our healthcare system and a big focus.
Goes to a hospital board meeting.
Yeah, anybody who's a chief of cardiology knows there's a big focus of cost containment in the U.S. healthcare system, and we've now seeing well over 1 million hospitalizations a year for this problem. Over half the money spent on heart failure, which is already a huge portion of our healthcare spending is spent on inpatient care for heart failure patients. So obviously a major problem